Well, welcome. Tonight we're going to talk about an area that definitely has everybody's interest. And it seems whenever there's a new medical indication that's got everybody excited, we call on the head of the infectious disease unit. Why don't we start with an introduction?
Hi, I'm Michael Newstein. I direct the infectious disease unit at Milford Regional Medical Center, and that's my position. I've been there for 14 years.
Hi, I'm Kim Knox, and I'm the Infection Prevention and Control Coordinator for Milford Regional Medical Center. I'm a nurse, and I've been there 12 years.
And let's see, you're supposed to take what they tell you and bring it into English for us non-MDs, right?
And that's exactly what I hope to achieve with all of my staff and with the people I encounter.
And I'm Jeff Hopkins. I'm the director of the emergency department at Milford Regional, and I've been there about 12 years now, taking care of, we see just under 60,000 patients per year. So we're a pretty busy community medical center.
So Michael, we hear about Ebola.
Mm-hmm.
People have all these misconceptions. Mm-hmm. It's airborne. Mm-hmm. You know, it travels through Star Trek, you know, being beamed around.
Yeah.
What is Ebola?
Well, first of all, it's a virus, so infections are usually caused either by viruses or by bacteria. So, like for example, the flu, it's a virus. So that means we don't have as good drugs as we do for bacteria. And we actually have known about Ebola for about 40 years now. There have been epidemics in Africa for the last 40 years.
They found it in '76, right?
Mm-hmm. So 39.
No,
yeah, yeah. So this what's going on now in Africa is bigger than any of the other epidemics, and now we've had just a few patients outside of Africa, which has gotten everybody's attention.
Well, when you start the founding of Ebola, mm-hmm. I mean, when I read about it, it's kind of interesting that it started with one fruit bat and one 2-year-old.
Mm-hmm. This latest epidemic, that's what they think based on looking at the DNA and the RNA and tracing things back. But again, there have been several epidemics in Africa that have died out, and they think it comes from animals, either bats or monkeys or apes. And the previous epidemics have been in small villages in Africa, and they were able to control these epidemics. This one, so far, is not controlled, and it's bigger than the previous epidemics.
And when you think about it, and you say control it, it almost mm-hmm. seems like the virus, it's a self-effacing population. It will control itself. Mm-hmm. Will it not?
Well, right now, we don't have effective or known effective drugs. We don't have an effective vaccine. But we know we can control infectious outbreaks without drugs or vaccines if we do good infection control. Isolate the epidemic, isolate the people. Ebola is a very serious infection and carries a high mortality, particularly in Africa. But if you can prevent it from spreading.
But now, when you think about it spreading,
mm-hmm.
what everybody gets nervous about is, we watch the movie Outbreak,
mm-hmm.
and all of a sudden it was getting kind of a lull in the action. So some writer came up and said, let's make it airborne.
Mm-hmm.
Now it can infect everybody.
Yeah.
But that's not the case with an Ebola.
Again, we know a fair bit about this virus because it's been studied for the last 40 years. And we know, and this is probably one of the most important things we'll say tonight, is we know how it's transmitted. It's actually not that easily transmitted. Another virus like flu, for example, that we spoke about on other occasions, that's easily transmitted. It's airborne. And then you have other agents like tuberculosis, which can hang up in the air and be spread even further. What the CDC says is if you're 6 feet away from somebody with Ebola, as long as you're not getting effective, as long as you're not getting infected fluids on you, you won't be infected. So I don't know if you and Jeff are 6 feet away or so, but somewhere
If
in
he's
that
got
area,
Ebola, I'm going to be annoyed.
you know, that distance, you know, it doesn't spread that easily.
But now when you talk about spreading, I mean, obviously, they say human fluids. So the obvious fluids, intimate contact, yes.
Yeah.
But Jeff and I are not having that kind of fluid transmission.
No, but
What else?
well, we know a lot of the infections are probably spread through gastrointestinal fluids, vomiting, diarrhea. Ebola has a tendency where you can bleed from different spots, so blood is very infectious. Saliva and possibly even sweat may be infectious.
See, because, you know, when I think of a hemorrhagic indication,
Yeah.
you know, and we hear about Marburg, the sister to Ebola,
Yeah.
but you don't hear as much. Is Marburg not that infectious? I mean,
Well, I think that's been an issue. You know, they've studied both in primates. My understanding is, you know, Marburg certainly can infect monkeys. They haven't been the crossover to humans as much with that.
well, you know, when I looked at the history of Ebola, you know, a fruit bat, you know, it starts what, with a piece of RNA wrapped itself in a protein sheath,
Yeah.
got into a fruit bat, infected a 2-year-old. Obviously, the 2-year-old feels sick. Mom brings him home.
Yeah.
Grandma was living, or somewhere, the mom decided didn't want to live with the dad, moved back to grandma's. Now all of a sudden, grandma's infected. She sees people dying around her and decides enough of this shaman stuff. I'm going out to see a real doctor. So travels to the big city.
Yeah.
Now it's out of the village. But you wonder, I mean, how does it keep going? You know, I can see sweat, but if I touched and left sweat there, and you touched it, can you pick it up that way?
Not very efficiently. That's not the way we think infections typically spread. You know, it's something we're extraordinarily careful with because, again, we know people get very sick and can die of Ebola, but the areas where people have been infected have been chiefly gross exposures or, you know, significant exposures. Gross can mean two different things, to bodily fluids. You know, we look at that poor patient from Liberia who came to Dallas. He lived with his girlfriend, the whole house. They didn't get infected. The unfortunate people got infected were the healthcare providers who were taking care of him when he was very sick. And we know one of the saving graces about this Ebola epidemic or Ebola in general is that it's not contagious when you're not sick. And it gets more contagious the more sick you get. So Mr. Duncan was, at the end of his life, was very contagious. And the people he infected were the healthcare providers.
But he's living in a house.
Yeah.
If they're not having sex, okay, you take that transmission away. I mean, you can be bleeding out of every orifice you have, and if anybody touches the blood, I would think the viral load's pretty high there.
At the end of illness, at the peak of illness, it's, you know, very high. It's billion viruses per, you know, teaspoon of blood, while, you know, the viruses I used to study HIV and hepatitis are 100,000 or you know, 1 million. So it's
So very efficient.
1,000 times more. There's a lot of virus.
But I still got to touch it.
Yeah.
So, you know, if I did bleed,
Yeah.
and I left blood somewhere, there's going to be a short period of time when that virus is still very active. Okay, I can understand that. If I touched you, you know, I think, Kim, you mentioned one of the problems they have is with funerals, that some of the cultural issues.
Right, and they do have some cultural mores where they touch bodies. And that's something I believe they're educating individuals about in Africa, that they don't want to change their culture, but they want to change maybe some of their practices at this time. And also, if you do come in contact with that individual who has those profuse infected body fluids, then that's an issue for you. If you've got it on intact skin, probably not so much of a problem, but it could be a problem. But if you've got it on the mucous membrane of your eyes, nose, and mouth, that's a significant issue for you, or a break in your skin.
So it really, I mean, when you came on, H1N1, oh my God, the world is coming, it's Y2K in a viral form.
Yeah.
And it came down to wash your hands,
Yeah.
But we did do a lot of prep for H1N1. So similar to this outbreak is we've had a sort of a very robust response from the hospital, not only our hospital, but hospitals across the state. We've had a lot of guidance from CDC and from the Department of Public Health in terms of how we're going to get ready and how we're going to prepare for this. And I agree with Mike and Kim that, the chance of someone actually coming in and presenting with this is actually pretty low. You have to have a variety of things. You have to have been in contact with someone who has had Ebola, or you have to have traveled to a certain part of Africa, not just any country in Africa, but Western Africa, one of these 3 countries where the outbreak is most prevalent, and then have contact with someone there who is having symptoms. You need to be able to bring that back to the States, and then you need to be having symptoms before you're able to spread the virus.
So it's the first 20 days, I'm really not symptomatic, correct?
No, the 21 days is the outer limit of the time between anybody could be infected and when they're safe. So typically the symptoms are earlier, within 10 days I think is the most common interval between infection and symptoms.
So it's really almost less than 2-week window.
Well, again, since it's such a severe virus, we know theoretically it can take up to 21 days. So, we want to minimize any potential infections or transmissions.
Now, if I'm not going to 3 countries in Western Africa, okay, that rules out a big risk factor. But I think about it, I'm going to London. There's a chance that I'm going to meet Mr. 19-day, just before they really start showing fever or symptoms. And I'm on an airplane. I could shake their hand. I could come in contact.
Well, they really don't think it's infectious until you have symptoms. And, that is, one of the saving graces of this. And it's a continuum. The sicker you are, the more transmissible you are. So, they've analyzed how people have gotten this, and it's been exposure to sick people.
But now, Jeff's going to have a good shot at doing tests. I don't normally go up to somebody and say, "Hi, Kim, do you vomit, have diarrhea? Do you, it's not quite dinner conversation that would ask, do you have these symptoms? What do you do?
Well, we have sort of a multi-prong approach. One is we're trying to get the word out by shows like this and by doing educational forums, meeting with our colleagues, reaching out to the primary care providers in the area, and really just trying to provide the latest, most up-to-date information, because it is changing. But I think, we want to get the message out there with knowing that we have the flu season that's about to come on us within the next couple months. The flu season, we've already seen our first case, but that's going to start escalating. So then you're going to have patients coming into the primary care offices, patients coming into the emergency department, and they're going to have these flu-like symptoms.
So immediately Ebola.
Well, that's what we want. That's what we want to prevent is having people think of that immediately. What we want them to do is ask the right question. So the right question to ask when someone comes in with a fever is, have you traveled within the last 21 days, and specifically, have you traveled to Guinea, Sierra Leone, or Liberia? So right there, you're going to cut out a bunch of people. Then you're going to ask, have you been in contact with someone with suspected or confirmed Ebola? And in the country,
Even, what, 2 people?
we've had 2 healthcare workers who have not gone over to Africa in the entire United States who have been diagnosed with Ebola. And you think of that sort of just on a perspective basis, there have been 10,000 cases in Africa. We've had 2 here, and we do have a very robust response in terms of getting our personal protective equipment set up. We have kits, we have protocols, we've had educational forums, we've reached out to our EMS partners, our pre-hospital providers, so that we make sure that even when you call 911, that if you have the right symptoms, if you call and you have an ankle sprain, they're not going to ask you about, have you traveled?
You broke your toe playing soccer,
Right.
Ebola.
Right. But if you say you've had fever and vomiting, there's part of the emergency medical dispatch is now asking that question. So it's really getting the word out and getting everyone on the same page so that we can kind of control who is coming into the primary care offices, who's coming into the emergency department, how they're coming into the emergency department if that should be the case. And again, I think the chance that we have a case is very, very small. But if we do, we are prepared and we have a plan in place, and the preferable way for someone to actually come into the hospital would be by ambulance. You know, if we have someone in an ambulance where they come in through the ambulance bay, we have a very defined protocol where we can limit the number of people that come into contact with the suspected patient. We have a certain designated area within the emergency department that's actually separate from the main emergency department that would be our treatment area, and it's actually made up of 3 rooms. Those 3 rooms has one area for what we call donning, another area for doffing, and we've talked about donning and doffing for the last...
Okay, Kim, time to translate.
Okay, putting on and removing personal protective equipment.
There you go.
So we have those 2 areas, and then the third area is actually the patient treatment area, and it has a bathroom adjacent to it. So we don't want to be having any suspected patients before we can send out that confirmatory test to the state. We want to have as few people come in contact with the suspected patient as possible, and we want those providers to be as protected with what we call PPE.
Personal protective equipment, guns, or in this case, we have Tychem bodysuits with hoods protecting their necks, special masks, and eye protection that covers their whole face.
So thank you for the translation. So we've gone over we've actually gone through a variety of different setups and what is the appropriate personal protective equipment. And that's changed even from the time of this first case in Dallas, where now covering the neck is actually involved. So in the part that we're really trying to teach at the hospital for the providers is how to take off that equipment. When you put on the equipment,
It's clean.
You're clean. But once you go and you treat the patient, and if you have vomit on your blood, it's really piece by piece, taking each piece off and having a very specific protocol where we have a buddy system and you have someone that's watching you do this. And as you're taking off each piece of equipment, we disinfect our hands between every piece that we take off. So nothing's perfect, but we think that we have a pretty good process in place. It's certainly what the CDC and DPH are recommending. And it's taken a lot of effort by these guys to kind of get that up and running. But we are ready. We're as prepared as we could be.
And I think the take-home message, just like when you came on for H1N1, is be vigilant, take care, but don't panic. My 90-year-old mother might get the flu. She might get a fever. She may have diarrhea. She may vomit. But the chances are I won't scream Ebola because she really hasn't left my house or, a close-knit group of friends.
Exactly. So, yeah, because what we've done, what Jeff and his group has done is get, as he said, prepared as we can be. But, the key thing is find out which patients we need to be concerned about. And we're hopeful that, and we expect it's not going to be many, if at all. And we have to be very careful. The key thing is that 21-day period. There are a lot of people in our neighboring communities who are from Africa or visit Africa for many reasons. And right now it's confined to 3 countries. It may or may not stay that way. In fact, other countries like Nigeria had Ebola and they were able to contain it. So if Nigeria can do it, I think we can do it. Yeah.
Now, when you think about treatment, there was a lot that we read about how in West Africa they don't have, the Taj Mahal Hopkins setup where you can plan, you can have everything. But if you did isolate somebody, how do you treat it? I mean, you always hear about, I got a bacterial infection, why did they give me antivirals? Or they gave me something for a bacterial infection, it's a virus, and the virus sits and says, more, keep feeding me.
Yeah.
If I got Ebola, I fly them back to the US. I give them a lot of fluids, I balance their electrolytes. Okay, so that's drinking Pedialyte or Gatorade, okay.
And that's probably the main thing, is to support people from the losses of gastrointestinal fluids. There are, the people who've gotten Ebola here have generally gotten other treatments, as you know, plasma preparations with antibodies or monoclonal antibodies, your sort of things. And so, there are treatments under development and there are vaccines under development. But right now it's supportive. And, if you look at what's the United States experience, we've had, many, I don't know what the final count is of all the different Ebola patients who've been either brought in or the 2 cases acquired here. We've had 1 death who presented very late, Mr. Duncan. I think, we probably could support people pretty well here. But another issue that we have to deal with is taking care of patients when we're in these what look like spacesuits, and being sure that we're extraordinarily careful with blood drawing and the specimens themselves. So the CDC and the Mass Department of Public Health have good guidelines of how to handle specimens, how to take blood, and we could certainly identify who has Ebola. What's nice about Massachusetts as opposed to other states is our state laboratory in Boston or in Jamaica Plain actually can do the test. So if somebody were to come from West Africa or happen to be exposed with Ebola, with a fever, we're thinking, oh, this could be Ebola. We're wearing the appropriate attire. We have them isolated. In several hours, we hope that we would be able to say yes or no, this is Ebola, and that's with the help of our state laboratory.
Now, the economics worked against us. When you think about some of the original diagnostic tests, it seemed like, especially the ones shipped to Africa at low cost, were very sensitive. The cholera tests. So they absolutely wanted to make sure that if you had a test for Lassa, that if there was Lassa, we're going to find it. But then didn't they realize that the false positive rate was like through the ceiling?
I'm not sure about those tests. I know, this is a PCR type test, RT-PCR, and it's sensitive and specific. So the test is good, and I guess they've tested it enough in our state laboratory that the CDC feels comfortable. They said, okay, you can do this on your own. So that's the one thing that we're an advantage of.
Well, if it's a PCR test, your confidence level is much higher than a field-based ELISA or an EIA test.
Right.
I can see them where originally they kept saying a lot of the Ebola people were Lassa victims because it was just a blanket. They wanted to make sure that if you had something, we quarantined you.
Right. And I think one of the things that we want to just keep in mind is again, not getting too focused on just one disease. There's this spectrum of disease that comes into the emergency department, comes into the primary care offices, that comes into the hospital. And this variety of diseases, you know, patients come in, they don't tell you what disease they have. They come in with a symptom. They come in with fever or vomiting. And then it's sort of up to the physicians and the nurses to kind of come up with what's the most appropriate initial stabilization, testing, and treatment. And all that time keeping ourselves safe. So I think that, you know, we are being extra vigilant with this obviously high-profile illness, but we're not losing sight of the fact that this could be just as well if someone went to Africa, this could be malaria.
Right.
And we do have the ability to run a malaria test actually at our own hospital. We have the ability to do influenza swabs. We do have a relatively quick turnaround time from our state lab here that is, like Mike said, is not requiring us to do a confirmatory test at CDC. So we have a good test. We have, I think we have the perspective down in that we are still looking for other illnesses, and I think by that early identification and screening out patients from asking just a couple quick questions, whether it be in the ambulance, at the primary care office, or in the hospital, I think that we can just take a lot of patients with these symptoms and say pretty confidently, you do not have Ebola.
Now, again, when we think about economics, I mean, vaccines have never been a real profitable investment. I mean, I hate to say it, but as an industry, when you look at the pharmaceutical industry, let's see, where do you get most of your vaccines? Jamaica Plain, because you're giving them to children for free. So by definition, there's not going to be much profit if you're inoculating everybody. So chances on these Ebola vaccines of seeing the light of day without a major breakout.
Well, I think there's an impetus now. Unfortunately, there probably was an impetus for the last 30, 40 years. What we know is it should work because we know the antibodies from people who are sick can neutralize the virus. So that means that you should be able to vaccinate somebody. And they're working. They have vaccines. They need to test them. And there's going to need to be government funding,
Right.
which I think will be there because we know what happens when Ebola breaks out and becomes an outbreak.
But now, if I've got to get antibodies from an infected person's blood, isn't it back down to the polio scare of many decades ago?
Where they felt that the inactivated polio vaccine was contaminated with other viruses.
You're putting polio virus into my body?
Well,
How do I know you did it right?
well, a couple of things. So antibodies are very sturdy, and I'm sure I'm preaching to the choir here. Antibodies are very sturdy molecules, so you can use techniques that would destroy any known living virus or bacteria and still have good functioning antibodies. So,
I mean, the antibody itself makes you feel better because when you think about it, protein A will give you a 90% purity from one shot, and by the time you go through concentration, diafiltration, the whole 9 yards, you're pretty well certain, and you do your testing, that there's nothing left in there but the antibody. And I think that's something that people have to understand. It's not even putting in deactivated virus.
Exactly, it's just the antibody. But, I think we'll have better drugs, we'll have vaccines. I think we're, in the infancy of this outbreak. And, I've been around enough that I was in medical school or undergraduate school when HIV was around. And the same fear of the unknown. We didn't have treatment for it back then. We still don't have a vaccine for it. But HIV is a trickier virus in some ways. But there's a lot of that same sort of fear. And it's interesting in the news that some of the old AIDS activists now are complaining about how some of the Ebola exposed people are being treated with the quarantine and such. But it's always a balance of public safety and personal liberty.
Well, let's look at that. I mean, I volunteer to go over and help because I'm a nurse. I've got some training here that I can bring and help. I come home and it's in the news, I'm put in a tent with no running water and no CNN. But, all kidding aside, where's the balance? I mean, as a physician, I probably know where you would come out about to quarantine or not. But as a human, if it was your daughter, your wife, how do you draw that balance?
Well, I know that's an area of a lot of debate, and I don't think there's one correct answer. Thankfully, this is not influenza. This is not, tuberculosis. It's not readily transmitted. So we know that unlike influenza, again, you can't spread it unless you're sick. With the flu, the big problem about the flu is you can spread it the day or two before you're sick. That's not the case of Ebola. So if we have close monitoring, it doesn't really matter where they're kept because they're not going to be contagious until they're sick. And as long as you can keep track of them, they can, as far as I'm concerned, they can stay wherever they want. But we have to keep track of them.
What happens if you find a patient in the ER?
Yeah,
what are you going to do?
Well, we would institute our personal protective equipment. We would isolate the patient. We would keep our staff members as safe as we can. But one of the nice things about the national attention that's been brought to this is that there's a CDC response team, and there's a number that we call right off the bat if you have a suspected case, that Mass DPH has set up a 24-hour hotline where they can help guide us through any variation of whether a patient comes in through the front door, by the ambulance bay, if it's found out later that a patient who's currently in the department wasn't asked at the front door about the travel history. We have that help, we have that guidance, as well as our own infectious disease team, but we also have a dedicated area. So we've sort of planned for the worst. So we hope that we don't get in that situation, but if we do, we have an area that we can place the patient. We feel that we have appropriate equipment so that we're using standard precautions all the time in terms of anytime someone comes in vomiting or coughing all over the place.
But then universal precautions take precedent no matter what, don't they?
They do.
Right.
When we think in general in a lab, you have to treat every sample as if it came from Michael's crew. If you don't know the history, we always told people everything could be infectious.
Right.
And so universal precautions
We
are
do
key.
that. We even do that on a routine basis.
We
I was
do.
working a shift on Sunday, and before going into the room, the patient had been coughing, and there was a setup outside the room for us to have a mask and gown before we went into the room. So it's not completely specific just to Ebola. It's for any infectious disease. It's just good practice in terms of hand washing, using gloves, using masks, using drapes when appropriate. So I think we do a lot of those things kind of without even thinking about it on a routine basis. And I think following those universal precautions is going to keep us healthy, whether it be influenza,
Exactly.
Ebola, tuberculosis.
I mean, things like TB. We hadn't seen TB in this area for a long time.
Well, we do have some cases. We do have a few cases. It's at a lower level, but
But what I was thinking of is we had immigrants come in, and they came from areas, it doesn't have to be an immigrant, it could be a traveler, where TB was still, a cause, something to be alarmed with. And all of a sudden, we had to put in a program where the visiting nurses had to go to the patient and watch the patient take the medication.
Exactly. And that sort of intensive monitoring is similar to what we're saying with people who are exposed to Ebola, people who are doing, as they say, God's work, going to Africa. And I know 2 physicians who are there now, one from University of Massachusetts, Dr. Hatch, and one from Brown University, Dr. Flanagan, who are big infectious disease workers, and they're there now in Africa. And we have to think about this because we're in Boston. There are a lot of medical schools, a lot of research people who are going over there, or people doing, for their own, for their own moral reasons to take care of these sick people. They're going there, and we want to treat them humanely, but protect everybody else.
So, in your mind, learning experience, will some of the things that I never thought of, when I think of the bunny suit, you zipped up the little Tyvek bunny suit, and you put on your little hat. Hated putting on the stupid one, but you put them on. But the neck was never, it wasn't like in cell culture where we worried about the interface between the glove and the sleeve and having, skin-borne bacteria that could contaminate.
Yeah.
But now, other infections, other indications.
Well, that's key because, and I've been talking about this to other people as well. I think this Ebola situation, this Ebola outbreak, is both a opportunity and there's some potential for being distracted from other infections. The potential for good is beyond Ebola, is that we're looking at people who are traveling in different places in the world. There are these emerging diseases. Behind Ebola and everybody's in public health concern as far as international infections, there's the Middle East respiratory syndrome.
The new avian flu.
Yeah, MERS.
MERS.
Or camel flu.
Camel flu. I don't
So that's something that's out there. It's simmering in the Middle East. So we're establishing protocols for the emergency room, but also other places in the hospital. Anybody who comes in with a fever, we ask, where have you traveled? And Ebola hopefully will be old news at some point, but in our world, there are emerging diseases that will keep us busy. And
well, it was amazing when you think of like dengue. Whoever thought? Or when you look at some of the hepatitis strains that you sat there and said, well, I never really even thought of those till we found out, back then it was East Africa, how many people from UN and State Department were going to East Africa and being exposed. And then they come home. And if you're not looking for it, or you're not practicing universal precautions at home, it just opens the door.
Well, we see in Little Milford Regional Medical Center, we see everything. We're on the 495 belt. There are lots of people from all over the world who work in high tech here. There are lots of, students who travel all over. So, we've seen, malaria, we've seen dengue. Haven't seen chikungunya yet, but we're looking for it. We see infections from all over the world, and it's an interconnected world. And then there are viruses jumping from animals into humans. So, that movie Contagion is an extreme case, but, that was based on science. These things can spread.
Well, Ebola in a fruit bat.
Yeah.
When you think about it, a 2-year-old kid, what's the first thing they do? Everything goes in the mouth.
Yeah, and hopefully, hopefully this will be a lot of preparation that we never have to really implement. But I do think that there's a silver lining to all of this. And I think we found it with H1N1 when that was a big scare as well. What it really showed, I think, is how a small community hospital can get ready for anything that's out there. There's going to be scares. There's going to be another scare after this one. And you know, for a team like our infectious disease team and for our disaster preparedness team to be able to respond to this, I was really proud of those guys for kind of bringing this all together and showing how we can respond to the needs of the community. One of the things that came out of the H1N1 was the state said you need to have alternative treatment spaces. So again, in talking about disaster preparedness, it'll help us out for something down the line. The fact that we went through this process of coming up with protocol after protocol for the H1N1, we ended up looking at our hospital and figuring out how can we sort of use different spaces within the hospital and have those as overflow spaces. So we've already identified those, and although we didn't have a huge surge of H1N1 patients who were dropping, you know, all over the place, we have that protocol now in place. With this response, we have a disaster preparedness response to an infectious disease. And I think that helps us stay vigilant. It helps us build the teamwork that is so prevalent at Milford. And it makes me really kind of happy to work in such a place.
Absolutely, and you know, we were trying to find the best fit as far as the suits. We had the fire department, and and we were all testing the suits. We had fun squirting water on each other, seeing if water could get in. So it was a lot of fun. But the key thing is that what Jeff said is this is a group that has been together. There's not a lot of turnover in Milford. It's a good place to work. You know, there are a lot of H1N1 veterans there, so you know, we just did a new drill.
Well, I was thinking, you know, you pick a new Tyvek suit or a new bunny suit. Well, when Ebola quiets down, you're not going to go back to the old suit if this is better. If you've sharpened up your protocols, maybe the next time, if it's an airborne scare, you got to look more at the high-vax side of the world, but the isolation, the quarantine, the universal precautions, the bar's been raised.
Right, and we learned things from the Boston Marathon. I mean, that was another sort of high-profile incident that really raised people's awareness. And I think all of those things, when you take all those experiences and then you actually act on it, and you're proactive, then I think it just makes it a safer place for everyone in the community, not only in the hospital, but our pre-hospital providers. We work with the police departments, the fire departments, the paramedics, and just having everyone sort of prepared for the worst, but hoping that, you know, that we're sort of putting in a lot of work that we're hoping we never have to use, but we are prepared.
And some of it's healthcare and infection control 101. You know, as you said, the hand washing is key. However, I was on a teleconference with the White House the other day, and they talked about stop, assess, and provide care safely, with an emphasis on the safely. I used to teach a lot of first aid for the Red Cross. Everyone always thinks you rush into something without being prepared, but that can create
More problems.
additional victims. You have to stop and assess the scene and see what's safe to do. And I think it makes all of us better care providers to take that moment and look at what's going on, make sure that we have the appropriate equipment, and that can change as we go through. There's a continuum here. It evolves.
Well, I think, too, what you've said, you don't want, I mean, you want people to be vigilant,
Exactly.
but you don't want my 90-year-old mother coming down with the flu yelling, Ebola. Because if too many people do that, you know, I hate to say the boy who cried wolf, but you could desensitize the whole community to the one that could be real. Now, opportune time to look at the new emergency room?
Absolutely. I think it's always an opportune time to look at the new emergency department. So we have the new ED is going to be, if anyone's driven by recently, you can see the steel is up, and we're going to be weather tight by this winter. If everything stays on schedule, fall of 2015 is when we're going to open. And really what this means for our patients is we're taking a busy community hospital that has a limited footprint in terms of where we can treat people. We have 15,000 square feet to treat just under 60,000 patients a year. So the math on that is I can't do it, but I can just tell you
I
that
met
means
a lot
crowded.
of nice people out in the hallway when I hurt my knee.
Right.
I got to
Right.
sit out in the hall. They kind of looked at me and said, yeah, you're old, but you're not really hurt that bad. You sit in the hall.
And the benefit is that you're going to have your very own room in the new emergency department. So the new emergency department is going to go from 30 beds up to 52 beds. And we'll have a couple rooms that are designated for the higher acuity resuscitation bays. And we were able to kind of go out to other newly constructed emergency departments and take sort of the best parts of each one and bring it back and sort of design our own layout. And it's not only an emergency department, but it's also an ICU, and it's new inpatient beds that are all private beds. So we're really sort of upping our game at Milford and giving people the privacy they deserve, the space that they deserve, and giving our providers that same space so that we can provide that care where we don't have to treat you in the hallway. We can treat you in your own room. And you know, the emergency department is sort of it's a chaotic place. There's a lot of uncertainty from patients when they come in, and we want to make that environment very calm, as calm as we can.
I would think the tension level is your first enemy. Because of all the people, Michael, I don't come visit you when I feel good. This is not like going down to Dr. Farouk saying, it's been 6 months.
Right.
You know, Fahim, just do a physical. If I'm visiting one of the two of you, it's probably not a happy day.
Yeah, you're not having your best day when you come in to see someone for an acute issue. So if you know whether it be a trauma or an illness, we understand that it's a very nerve-wracking time for both the patient and their family members, and I think we want to have an appropriate environment for that, so that we can sort of set the tone of that calmer area where we can provide compassionate care, where we can really focus on the patient and not so much worry about the bells and whistles that are going off and the different alarms. We want to have a sort of a soothing environment when people come in distress and sort of, it's probably having the worst day of the year for them.
Now, when you talk to Uncle Frank and Ed, they were so proud of how much time that all the department heads put into thinking about the design rationale phase. Anything have to change with this new Ebola scare?
No, we have some of those things that are standard for our emergency departments. A decontamination area is sort of standard. Our resuscitation rooms are standard. We have negative pressure rooms that are standard. We did take into consideration a couple of things that weren't specifically related to infectious disease, like being able to take care of patients who were heavier than we could take care of prior.
He's looking at me when he says that.
So we have lifts that are actually in the rooms that can help us out, and just, we're sort of evolving with the times. But I think certainly this outbreak and all the attention has put us in closer contact with the community, hearing what the community wants in a medical center with our pre-hospital providers. We've had input from the police department as well. So we're trying to make it a secure place, a safe place, and a place where we can provide the best care with all that input from multiple different specialties and from members of the community.
But that's a good testament to how much work went into the planning of the new ER, ICU, the whole area, that you could take on an issue like Ebola and not say, oh my God, time for a redesign. I mean, that makes my confidence level go up, that, okay, I got to go through a new bunny suit. Kim gets to spray water on Michael. Okay, she probably said, well, I don't like that suit, try another one, I get more water. But
No, I spray them with other soap.
But you think about it and you say, if you had to do major redesign, then I'd be a little bit more worried about the due diligence process.
Yeah, right. And even to expand on that, we've looked at this more recently and looked at even 20 years down the road, if the medical center is going to expand 20 years down the road, the building is set up so that it can take another couple floors
Couple
on
floors
top of
up.
it. And we've created an area where we've cleared out some land so that if we need to expand laterally, we can do that as well. So I think the thought process, we had a great team. We had a great team of architects. We have a great construction manager, and we have a great team with Consigli, who's building the actual the building. And I think they've really, I think all that effort, you kind of wonder, geez, why are we having another meeting about, you know, this planning has gone on for so many years and you have all the different groups. But I think that's why you do it, so that you can look forward to, because we don't know what the next Ebola is going to be.
You know, and when you think about it, having somebody like Anthony, the Consigli Group, making our hospital better. You can't ask for anybody who's going to care more about the town than a family who are Milfordians.
Right.
Now, Kim, question for you.
Yes.
You know, we started off with Ebola. Oh my God, it swims, it jumps, you know. The layman wants to learn a little bit more about Ebola. And I love these guys, but they're going to talk at a level that they're going to need a translator sometimes.
All right. Well,
How do I get the information?
I'm here to interpret and to tell them where to go. I always suggest that individuals go to the Massachusetts Department of Public Health or to the Centers for Disease Control websites. When you go to the CDC website, their main page has a huge icon for Ebola, and you can click on that, and that will bring you to information not only for healthcare providers, but also for the general public. They also have webinars that individuals can log into, you know, and that would be good for a variety of different levels of individuals, and even question and answer sessions, so people can bring that information. And you want to go to one of those valid websites, because you're not going to get inflammatory information. You can get information that's geared for the public, that's geared for other specific groups, and also that is valid.
And I wanted to bring that up because it does concern me that you have the National Enquirer type, that they want you to read about the three-headed alien that had dinner down at Johnny Jack's. And by the way, Ebola is, you know, the thought of Ebola is spreading, and you hear that, you see the thought about this big, and Ebola spreading in Milford. So, you know, going to what I would call reputable websites, whether it be an NIH, whether it be a CDC, I would start with CDC.
And that's where I usually start, in Mass Department of Public Health. And, you know, there are other sites also, as you said, NIH, but there's really a wide variety of information available to individuals there. And there's even actually links where you can contact them. So you could write a question if you had one, you know, and have them respond to it within a few days, you know. And of course, individuals actually call Milford Regional Medical Center and call our department and say, what do we do with this? You know, what are your thoughts on it? You know, how do we manage this?
But if I call the main number,
Yep.
I probably should say more than Ebola, right?
You should say, may I speak with someone in the Infection Prevention and Control Department?
And then they'll get you, and
We're
you
very
can
happy
educate
to take their calls.
Michael, takeaway message. Be vigilant, but be aware.
Yeah, be vigilant, be aware, and also just keep things in proportion. You know, 30,000 people die each year of influenza. It's coming up to be influenza season. You know, 2 people, and hopefully not many more, will have died of Ebola in the United States. I'm sorry, 1 person has died, 2 people have caught it. So we have to keep things in perspective. It's a dangerous virus. We don't think it spreads very easily, and we got issues we have to deal with right now as far as ongoing infections, and we're preparing for this potentially dangerous infection. But you know, we have to be prepared, but keep it under perspective.
And I mean, you brought up 3 countries. So if you haven't traveled to the 3 countries in West Africa,
Yeah.
right? Sierra Leone,
Guinea, and Liberia.
and Liberia, and even Nigeria is now off the hot list.
Right.
But those would be triggers. if you're traveling to international centers like London, Paris, whatever, just be extra vigilant.
And you would need to be in contact with someone who had been to one of those areas, and not only had just because they had been to one of those areas, but had symptoms. So someone, as Mike had said before, you have to be symptomatic to be spreading this. So you really have to kind of know someone who has Ebola to get Ebola.
So as always, I think the message is, I mean, our medical center is expanding, and here's, you could say the #1 threat, at least publicly, that's in the news, and yet I don't see any panic. I mean, I see concern, and I would be less than impressed if you weren't concerned, but not concern over handling it.
Yeah, I think we, thoughtful pragmatism with a, being prepared for the worst, but expecting the best, and knowing that what we have in place is the most up-to-date, latest guidelines, and it will change, and we will change with it. So this will be an evolving process, but this is something that we take very seriously. But again, we don't want to blow it out of perspective, and we want to make sure that members of the community know that we're on top of it. And if there are cases, we know how to handle it, but that we don't want to have people worry about something that may never affect them, and more than likely
But
influenza
you dealt with
will
something
affect.
much worse with TB. It
Yeah.
was here.
Right.
We had it here. Nobody panicked. Control procedures were put into place. And I won't say it went away. We still have to stay vigilant, but it was handled. Thank you. And as always, to our 6 loyal viewers, and we may be up to 7 or 8 with the medical show now, it's something that we all should be incredibly proud of. Town meeting in the fall, rezoned area to allow more support offices of the medical center. The community has come up really strong to support our medical center. We all should be proud. And as always, God bless, good night, may tomorrow be a healthier day than today. Thank you.
Thank you.
Thanks.
Not too long since I've been home. Been running all my life just